uncomfortable potentially.
Litigation for the ST joint.
What did you just say?
She said scapula.
Okay, so the big reason we're going to start out doing this is so we can assess how the scapula moves. Obviously, we would have to assess both sides to really know if there was a difference. But you have a couple different factors when you're assessing if someone, like, let's say they have impingement, they're having trouble lifting their arm. It could be, if it's in the mobility category, it could be that their glenohumeral joint's not moving well, but it also could be the scapula, so that's something you have to check. So what I do, I just put my arm right under here, under her arm, find the inferior angle, right? And then I just try to get a lock on it. Either I may even make a V with my thumb and index finger, if I can get it there. Sometimes I may just try to grab my hand on it. It just depends on. With her scapula, I can actually grab my fingers around it if I want and actually move it. Some people it's harder, it's tighter, and so I just try to as much as I can. My other hand is kind of going around her acromion joint and around her clavicle, spinous scapula, just right in there. I'm getting up close, and I'm just assessing. I'm assessing her upper rotation. Can you guys see that? I'm shifting my body to assess that. I can take her to end range.
Whoa.
Kind of assess here. I can assess downward rotation. Here, for me, I may even push my thumb into it a little bit and assess right there. I can check is her medial border, is it tight? With her, I can get my hands all the way in here. See that? I can pull up here. Looks weird, right? But you can try doing this with some people. Hers isn't tight. I can even get in up here. Is that comfortable enough? Yeah, see? It's usually not that uncomfortable. So I can check. I can say, well, it's easy to get my hands here. So I can move. I can check. I can get my fingers right under here. You see how my fingers are kind of around her inferior angle? And I can move her up into an elevation position, depression position, right? So I can just see the movement. Upper rotation, downward rotation. So, for example, if they were limited in abduction, we could look at, is their scapula able to actually upwardly rotate? Does it move? Is it really locked down there? Does it actually, can I lift the medial border up? This is like our, when we had practicum tests, we would say, they would say, glenohumeral joint, 3 out of 6, right? Which is normal range of motion. And then they'd say, what else could it be if you're going down the mobility category? So then if we didn't look at scapula, we'd get marked off. So they'd want us to treat it at that point. So some of us wouldn't necessarily remember that upward rotation would help if you're trying to do abduction. So our go-to was just this, we can even get both our fingers in here and distract the whole area. Like I can get my fingers wrapped around here. And this was like our go-to help with anything mobilization. So that's the first thing. I want you guys to just practice that, and then I'll show you some more things from this position.